Okay, I think we've got a majority of people here, and we'll wait as people trickle in. I'd like to start this off. Welcome to the C-Suite panel, COVID-19 response. And we have a welcome by Aetna.
Aetna Better Health of Kentucky is proud to be an anniversary sponsor of the 2020 Virtual eHealth Summit. KHI and Kentucky's Regional Extension Center's work ensures near real-time access to data, and that is critical to helping us provide the best care coordination and support possible. We look forward to growing our partnership with them and the provider community as we begin managing the new Supporting Kentucky Youth program, also known as SKY. There is no need for a new SKY provider contract to continue seeing your SKY patients, and we encourage all providers to visit our virtual booth to learn more about providing services to SKY enrollees. It is our great pleasure to introduce the next session, the Healthcare C-Suite panel on COVID-19. This panel will be moderated by Mr. Robert Putt, the Executive Director of the Office of Health Data and Analytics, and will be both insightful and groundbreaking as panelists review lessons learned, hard-earned successes, and the future outlook of the post-pandemic landscape. Joining him to share their perspective on the impact that COVID-19 are Dr. Brett Oliver, Chief Medical Information Officer at Baptist Health, Dr. Judy Thoreau, Medical Director for the Kentucky Department of Medicaid Services, Dr. Brent Wright, Associate Dean for Rural Health Innovation at the University of Louisville, and Dr. Zary Ozanek, Northern Kentucky University. Thank you again to KHI for putting this event together, and thank you to all the participants for all you do for the people of Kentucky.
Hi, I'm Robert Putt, and welcome to our panel discussion today with health executives. It's a privilege to be here with these individuals. We have represented with us today medical directors, chief medical information officers, and deans, etc., from various segments of our healthcare economy. And plus we have representatives from state government, we have public educators in higher ed, we have university medical centers, and then we have hospital healthcare providers. So it's a nice mix of individuals and representatives. We're very grateful for each of the individuals who are with us today to talk about COVID-19, their organizations, their response, and how healthcare technology has assisted during that during the pandemic. So our objectives for the session are to first discuss the high-level impact that COVID has had on the organizations. Second, our objective will be to discuss how healthcare information technology has supported the pandemic efforts. And third, then we will talk about how KHI or the HIE has assisted and added to their organization or could potentially help down the road based on what we have learned throughout this pandemic. So we will do this in a panel discussion. We will open the floor for the panelists to first answer, and then we'll direct certain questions to particular individuals on the panel. Again, we're thankful for Aetna's sponsorship. If you have questions during this time, please enter those in the Q&A box that is located, I believe, at the bottom of your screen. And we will take some time at the very end to address some of those questions that may come about. As was previously discussed, we have Dr. Gary Ozanek, who's the director of Northern Kentucky University's Program in Health Informatics. He's also been the past national co-chair of Interoperability Work Group for the National Chair of the HIE Committee for HIMSS. In addition, he has spent 12 years in the private sector in a whole different world as an analyst for technology and telecommunication industries on Wall Street and as a consultant for Booz Allen and Hamilton. He's also served as the Associate Director of the Institute of Teleinformation at Columbia University. He's been on the faculty of Michigan State University and the University of Buffalo and holds his PhD from the University of Wisconsin. Welcome, Gary. Along with Gary, we have Dr. Brent Wright, who's the Associate Dean for Rural Health Innovation at the University of Louisville School of Medicine, where he serves as a professor, and he's also Vice Chair of the Rural Health within the Department of Family and Geriatric Medicine. He is also a current board member of the Foundation for Healthy Kentucky and is the immediate past president of the Kentucky Medical Association. He has also served as the president of the Kentucky Rural Health Association and president of the Kentucky Academy of Family Physicians. He has a great interest in helping to certify family physicians and has been working through both the Glasgow and Owensboro areas, along with Owensboro Health in that process, and has helped advance the HRSA funding towards the needs of our aging population in Kentucky. He's also a member of the New England Journal of the Medicine Catalyst Program. We're happy to have Dr. Wright with us today on the panel. Thank you.
Thank you, Robert.
And then Dr. Brett Oliver, who is the Chief Medical Information Officer for Baptist Health. He is certified in family medicine and has been spent a lot of time in health IT technology, overseeing an EHR implementation and development. He is a member of the Health IT Advisory Council for the Office of the National Health Coordinator, and has obtained his bachelor's from Vanderbilt University and his medical degree from the University of Kentucky, along with residency at Wake Forest. He's a member of several associations, including the American Academy of Physician Leadership, the American Medical Informatics Association, and the American College of Nutrition. Welcome you, Dr. Oliver.
Good morning. Thanks, Robert.
And last but not least, Judith Anterio, who is our medical director for the Department for Medicaid Services here at state government. Prior to that, she served as the medical director in a very important role for the Commission for Children with Special Health Care Needs. Dr. Thoreau has attended medical school at the University of Louisville, went on to complete her pediatric residency and serves as the chief resident and on the faculty of the University of Louisville. She continues to serve as the director of some general pediatrics clinical research and has also been the medical director of a very important organization, Children and Youth Project, that works with inner city high-risk children in the Louisville metro area. She continues to serve as a professor of pediatrics at the University of Louisville. Also, we welcome a very busy lady, Judy, to join us also on the cabinet. Thank you.
Thanks. Great to be here.
So let's get started. Again, as you can see, we have a very great panel with representation across the board in the Commonwealth and from various segments. Let's start first with Dr. Oliver, if you don't mind, to talk how COVID has affected your organization. And then we are going to open this up for others to contribute. But just basically, how has COVID affected your organization? And secondly, are there particularly unique challenges that you have faced during this pandemic that may have not been expected?
Sure. Thanks. I'm glad to be here. As I was thinking through that question, how has it not affected our organization, right? I mean, that's probably the easier question. Every clinical workflow, nearly every non-clinical workflow, administrative workflow has even been affected, from things like if you're going to be in the building, you have to be screened, to if you're going to have a procedure, you have to be tested now before, not to mention the 6 to 8 weeks that we had where we shut down elective procedures. So then that affects finance, that affects every aspect of the organization. So we're still digging out of cancer screenings. I just had a patient this week states that she's trying to be compliant with what I recommended for her screening mammogram. The first time she could get in is mid-January, and she's just not used to that. And of course, that's a concern that you're going to be missing some cancer screening on patients. But and then one of the more unique challenges to COVID, because of its infectious nature in terms of a problem and quarantining and things like that, is staffing challenges have been really big and difficult to overcome. So keeping track of quarantine recommendations, keeping track of surging, things like that has been a real challenge. We've had, from an IT perspective in our department, we had a lot of IT projects that if they weren't COVID related, they were on hold, at least for the time being. We're trying to pick those back up late summer, early on. There was a little bit of joy in that, in the sense that you had the entire organization pulling in one direction for one purpose. And so that was really neat to see. I think we're too fatigued on that right now. I think we just as soon be done with that and get back to more regular operations. But I would say probably just the fact that it touched everybody from a financial perspective, from a staffing perspective, and folks that normally don't have to worry about what's going on in the clinical realm became acutely aware of what was happening. So I'll leave it at that.
Very good. Dr. Wright, would you like to speak to how COVID has affected your organization and the unique challenges you have seen both there at U of L, but also in the rural setting?
I think Brett outlined it so well. I think what I'll bring it down to more of a human element. It showed us how vulnerable we are. And, in the midst of this disease, and the irony of, to me in the early days, was the fact that we were challenged to see patients while keeping patients away, because the social distancing element of keeping patients away, it was like, oh, these people are sick, keep them out of the office. And, it just, every day, the irony in sort of the paradoxical nature of that is just hard to believe. And there was a lot of challenges in how you utilize technology. And I'm a big advocate on technology, that you have to go with a high-tech mindset, but you can't forget about basic technology. You can't forget about how good the telephone is. I remember being in meetings and people are like, how are we going to contact these patients? How are we're not set up for telemedicine yet. I'm like, we have their phone numbers. Let's call them. Let's do welfare checks. Let's just jump in there. And because, in the midst of COVID, in the midst of a crisis, everyone has to, we talk about in medicine, you have to check your own pulse first. Well, I think in the midst of a crisis, you have to check your own humanity first and realize, even though you're a doctor, you're a human being, and you're dealing with this, and you're on your own stress scale, and your patients are dealing with this on their stress scale. And, we found just reaching out technologically, the low hanging fruit of a telephone really helped out. And that was a great tool for us. It showed us how much we took for granted in this, because we have had to rethink every workflow. I think about, I'm going to use this phrase, if you're doing bingo, put this in there, unprecedented, I'll give you that. Good old days, you can put that on if you're playing COVID bingo. But just think about how nice it was for patients to walk into a waiting room and sit shoulder to shoulder in a waiting room and be called back without having to be escorted. We escort every patient in and out of the building to make sure that they're not in contact with anybody who could be infectious. So, thank you, Brett, for how you outlined that. I wanted to give you more sort of, a different version, how we're sort of facing it here. TJ Sampson's a regional hospital where I serve, but we're a small system in South Central Kentucky. So I think a good contrast there. So no, thank you for the question.
Great.
Robert, if I could just jump in for a sec.
Sure.
Could I jump in as an educator for a second?
Sure. I was going to save you for last, but go ahead. Jump in.
Okay.
Really, what have you seen from an education perspective, but also what have you heard across the board from other places being involved with interoperability national?
Sure. I just wanted to really touch base with and amplify what the clinicians were saying here. as an instructor, I've had more than 60 nurse practitioners taking a course from me since the pandemic ensued, working on their DNP, their doctorate. And I mean, a lot of them are frontline family practitioners, they're frontline, and I mean, they've been ravaged with COVID. The number of my students who are out there on the front lines treating patients, doing the COVID testing, and I think that's one thing we really have to, really take our hats off to them. It's amazing to me they've all been able to juggle their education and the like, but I think we can't forget the clinicians and not as a clinician, but as somebody who teaches the clinicians and really sort of engaged in their day-to-day deliverables and their struggles with meeting the course requirements. I was just amazed at their dedication. So I just wanted to follow in there for a second, Robert. In terms of what's going on, in terms of some insights or visibility I'm on 3 active research contracts with the ONC right now. And, I think health information exchange and interoperability has always been a key priority, but I think a lot of the issues have been laid bare relative to the ability to trace, the ability to exchange data, the ability to provide continuity of care, the ability to look at comorbidities with individuals who have diagnoses and the like. So I think that's a key piece in terms of looking, and we could go more into the details of some of the issues of interoperability as we go into this panel with the lab results and the like. But I think at a high level, and certainly the ONC and Brett, you can jump in here too relative to HITAC. I think the ONC is really looking. I think they always appreciated, but the larger focus of all providers on the importance of interoperability and integration of data and ability to get the full picture on the patients has become even more salient in this pandemic. Also, the focus on minority patients and populations that were adversely affected also is key. And then finally, televisits. So I think maybe we can touch upon all of those eventually. So. Sorry, I jumped in, Robert. I'm always enthusiastic.
Well, thanks for outlining our discussion, Gary. Typical instructor. Here's the syllabus. Okay, no, you're great. And actually, many of the points you made, I heard a little bit of our session previously following Dr. Stack's opening, where Mike Schutze, our Chief Analytics Officer at the Cabinet, talked about much of the data and the HIE and some of those intertwined messages and information that we'll talk about later some more. Dr. Theriault, relative to Medicaid, what have you seen as far as the effect of COVID and unique challenges? And there's nothing like the need for presumptive eligibility during this time period.
Oh yes. Back in March, Medicaid went into overdrive. Lots of little pieces have to happen to make changes in the system. And we've started off back, in March saying that we need to make sure that anybody that needs coverage will get it. And that caused changes in our presumptive eligibility requirements and our form. Now it's a 1-page form, made it very easy for people. And of course, doing that, lots of things in the background have to change. But we've also made it so that the day that you apply for your presumptive eligibility, you receive it. So it's not the next day or the day after, it's the day you actually apply. So I think that really helped increase coverage for people in the Commonwealth. We had almost 200,000 people join through presumptive eligibility, and presumptive eligibility is like a stepping stone. So you get in with this easy form, and then you have several months to complete the permanent form to get permanent eligibility. So that's a lot. It kicked our numbers up to about 1.6 million people within the Commonwealth on Medicaid, which is about 34% of the citizens. which is amazing to me. And it's 61% of the children in Kentucky are on Medicaid. So we really expanded that. Another thing that we really saw as a priority is to make sure the members that we have access to care. And so that involved doing several waivers, emergency waivers with CMS, changing regulations within the state, emergency regulations, and some of that had to do with telehealth. So telehealth really expanded because of some of the changes that we made, allowing different providers to perform telehealth. So I think that really helped. And again, lots of little different moving pieces to try and make that happen. And then the last thing that we really saw as a priority is to making sure that the providers get paid. And that had different, aspects to it, bringing CARES Act money in, extending bed hold days for long-term care facilities, different things like that. So I mean, a lot of different things happened, very, to help the people on the front lines receive payment and care for our patients. And I was shocked at, that everything got done and everything's working. One of the things that we did was we got rid of the prior authorization requirements for a time, because we thought our providers are busy enough, taking care of patients, and we didn't want to have any barriers there. And then things, settled down, so we put them back in, and now things have ramped up again, and so we've removed those PA requirements a second time. So we're trying to be flexible, trying to be fluid, and address the needs of our providers and our patients.
Great answer, thank you. Let's talk a little bit about now the different technologies that you have implemented in your arenas, or that you have seen become important throughout this pandemic, that have helped you overcome any of the particular barriers. We've mentioned a few things. We've mentioned everything from the phone, which is federal HHS has and CMS has allowed as a form of reimbursable treatment during this pandemic. We've mentioned some things about telehealth and telemedicine, but what other technologies, and please feel free to elaborate on some of those, because we'll be talking then about post-pandemic later on during the session. But what has helped you overcome some of the barriers that you have encountered, whether it's seeing patients physically, in person, or other barriers where technology has played a role in overcoming those? So if I could start with Dr. Oliver, I'll let you start with that question.
Sure. Well, let's start with all the folks that we had to get home to work. Sort of an operational standpoint, we, over the course of just a week, 10 days, got thousands of our Baptist Health employees home to work safely. That's not an easy task, making sure, bandwidth, equipment, access to the network, all those kinds of things. So it's not one that you think about often from a clinician standpoint, but it was a big deal to support the clinicians. Along those lines, a lot of our surge planning, the average person maybe not think about. When you're talking about getting beyond the normal rooms in a hospital, rooms in a clinic, where are you going to put this surge if it happens? Where are you going to create a new ward from an OR rooms or recovery rooms or procedural rooms? Well, all that has to have some tech on the back end to support it. So a physician, a nurse, a respiratory therapist knows where to find the patient. Where are they? And so getting all that surge planning, that was weeks in the making of making sure that from a technical standpoint, our EHR could support that. When we said we're going to go and add this unit, it was done. We added the unit, patients would be housed there, and the clinicians would know where to find them. We immediately created a COVID dashboard, bringing in data from across our system and some other resources as well. And that's where KHI would come into place, but so that our leadership could see which ones of our facilities, testing numbers, ICU beds, ventilators, things like that, That was key in helping make some management decisions early on. Of course, we talked about a little bit about telemedicine, but nearly every organization, every practice I know went from very few to very many overnight, and standing something like that up deserves to be mentioned again, because it was just remarkable. And it's interesting in talking to other CMIOs and other healthcare leaders across the country how similar our situations were and overcoming some of those things. One of the pieces that was interesting to have to overcome was our own internal processes from an IT perspective. We had a lot of team members that were so very uncomfortable about rolling it out as fast as we did. Brett, we haven't tested this, and this. I don't care. We have to have this live by Monday when such and such is in clinic or is in, back in the emergency department. Yeah, but it may not go okay. It's okay. I'll take the heat for it. We've got to get it out there. And so that was just an internal barrier that now you can go back and look at and see all those steps that we normally put into place. Are they still necessary? Did we learn anything? Can we shorten the time course? So anyway, that was a very interesting insight that we saw. Remote patient monitoring took on new meaning. We had a pilot going on to try to keep our CHF patients and COPD patients out of the hospital with some continuous remote monitoring. We quickly pivoted there, and part of our surge planning, if we had to utilize a hotel or a school dorm, something like that, how are we going to monitor them there? So that was part of that planning, as well as getting the patients out of the hospital a little bit faster. We've learned a lot clinically over the last several months, but early on, as some of you all may remember, it was very unclear. It seemed like the patients would go along just fine and then have a DSAT, end up on the ventilator very quickly. And so there was an uncomfortableness to maybe we should hold on to them for a few more days in the hospital before we send them home. And so the remote patient monitoring allowed our hospitalists and clinicians to feel comfortable, patients feeling comfortable going home, knowing someone was keeping an eye on them. I had a patient of mine who had the monitor on for about 6 weeks, and I called her and said, okay, we're going to come out and get that now. And she was very uncomfortable with that. Like, she was doing great, but it was like, someone's keeping an eye on me. I don't know. This is very comfortable, which was an interesting, I would have thought as soon as you could be off of the monitor, you would want to be, but she really felt comfortable with that. And then one other thing I'll mention is electronic case reporting. And I mention that specifically because we're working through that with KHI and the state health department. But you can imagine the burden on our infectious disease teams in our facilities reporting all these COVID cases. I mean, we're 3 to 4 times what we were in May, and having to manually report all these cases is a big FTE, big staffing burden, when I already mentioned that staffing's a challenge. And so we're working, KHI has been a great partner. One of the challenges maybe or barriers for the future that we can talk about is when state governments and federal governments mandate things, but they don't have the technology on their back end to support, it becomes a problem. But electronic case reporting is one place that we're working right now with KHI and can prove very fruitful in the future.
Thank you. Thank you much. Dr. Wright, would you like to talk a little bit about how technology helped in your practice and in your environment with overcoming some of the barriers that the pandemic presented for patient care?
Good. I appreciate the opportunity to answer this. I'll take a little bit different turn and go again. I like simplistic approaches, and I think that you look at everybody's virtual skill set as we've gone from March until we're here in December. I mean, just look today, we pivoted for a state meeting where we usually meet in the same hotel ballroom to where we're now meeting on Zoom. And I think I'll scroll down here and look, I've got 143 participants. That probably rivals our live meetings. And it just really goes to show you how quickly we can pivot and how quickly we can learn new skill sets. We're going to come out of this pandemic with 2 skill sets: the skill set that we knew going into it, seeing patients in person, and then this new virtual skill set that we'll continue to build upon. Now, I'll take you a different path here and wear my university hat and talk to you about a project that we did. We looked at smart glass technology. So I don't know if people really understand what smart glass technology is for telemedicine administration. I'll say this: Google Glasses. Most people will say, oh, we remember Google Glasses. They got some, bad press, and Google sort of put them to the side. But we worked with a company out of New York that had a really good product. And we worked in February to get ready, February and March, and we started testing that product. So again, if people are scratching their heads and saying, really, what are smart glasses? Imagine the glasses that I have right now with a camera. and a microphone, and everything that I'm seeing, I can transmit to you. And imagine everything I'm seeing, I can transmit to you. I can send you a text message and you can link into what I see. So now imagine that I'm looking at a patient and you're an expert and I need your help. Then I can still send that message. You can look at this and I can bring you into the patient visit via smartphone. So I'm using that as an example to show how within the midst of this pandemic, we look and we seek solutions. And that's one way that I think that's one, I'm looking at silver linings now in COVID. I'm looking at, rather than be on the downside of COVID, I'm looking at the upside. You know, how are we going to take these tools that we learned during this pandemic and really provide even better patient care? Because I think that we're oftentimes, if you reflect back pre-March 2020, I think we were still stale. I think Gary would agree with this. We look at a lot of futuristic models on the national level, and Brett as well, you know, how we need to have ubiquity in healthcare information, that, you know, the holy grail that we've been chasing for, you know, over 2 decades now. I think that COVID is going to create a sandbox of innovation where we're really going to see some great things coming out of this. And I'll tell you, the smart glass work, getting that in nursing homes and getting that to home visits, people who will not come into the office, but also are not going to be virtual visits. And to have them to bring the expertise of someone into that visit with trusted clinical providers, I think that's just opens up a new realm. And I can tell you people are interested. The Zoom call prior to this was with another state, a large Midwestern state that really is interested in this project. And it gets to the educational component too, because we utilize this smart glass technology to put video within an ER setting, within a clinical setting, to also bring learners in. So imagine right now if we were seeing patients, but we had 143 participants or 143 learners on this call to see one clinical encounter, that you couldn't get 5 people in an exam room. You couldn't get 10, but imagine bringing 153 people into that exam room. And that was some of the work that was shown out of the ER at U of L, you know, and we're just early stages of this, but it just goes to show you that within a crisis, I think there's great promise. Thank you.
Great comments. And I think both of you have indicated about the future. Remote patient monitoring, I find very interesting, because that is something that has been in discussion a lot around telehealth, telemedicine going forward. I find it quite, I guess you would say, encouraging that someone doesn't want their alarm system taken out of their house, but would rather deal with it and have that security. I think also the ability, as you said, for individuals who may not want to do a virtual session completely, or to come in the office, but some of that is neutral settings, whether it's a library conference room that the veterans have talked about and worked with, or whether it is potentially a local public health department and a particular room set up for telemedicine, along with someone to facilitate it, to see a specialist who's maybe 3 hours away. Lots of opportunity, as you said, on the upswing of this for flexibility, not only for the patients, but also for providers, and hopefully a better continuity of care going forward because of these different mechanisms and barriers we've had to overcome during this time. Gary, would you like to add anything to our conversation about the barriers and how technology has helped during this pandemic?
Yeah, I'm actually interested in, especially on the Medicaid side, implications, well, actually everybody's side, the implications for finance and sort of the economics of healthcare, right? I mean, the research literature prior to the pandemic on telehealth indicated that an increased access did not decrease costs, right? I mean, you just ended up bringing more people into the system and not necessarily lowering costs. So, you know, one question I always have is, as we look at these technologies, you know, the sort of ROI and the value propositions that they provide in terms of reducing costs as well as improving outcomes. So, I mean, I think that that needs to really be researched at this point. I think we really don't have a good handle on, I mean, as everybody's indicated, there's so much going on with not seeing patients on a regular basis and interruption of revenue streams. So I think that's, televisits and remote monitoring is really interesting. It's just a question of, making it economic to happen. And as we mentioned, earlier, the whole idea of being able to get the complete picture of the patient through and the case reporting and sort of how to automate that. I think Brent, you made the point. We've been chasing interoperability for 2 decades now, and I think this pandemic also shows you where a lot of good things have happened, and also where the challenges continue. Not every state has had the success that Kentucky has had relative to KHI. I mean, many states don't even have really HIEs in place, so it gets very complicated when you're using the vendor networks and the like, and public health reporting itself. So I think there's a lot of moving targets, but I think certainly probably telehealth and remote monitoring is the most interesting piece. I just really wonder where the ROI is on that in terms of offsetting the costs. I don't know if anybody has any thoughts on that.
Yeah, could I jump in there on that comment, Gary? I think that what we're seeing here, we're moving from the patient-centered medical home to the medically centered patient home. And all of these electronic equipment pieces, they're going to be centered in the patient home. I mean, you look at the Ring doorbell. Just take a few steps now, and let's say we're going to have a Ring doorbell, but it's going to be in the home and it's going to connect patients to their doctor. But it's going to take somebody with that mindset to drive that cost down it's not going to be a $5,000 installation. It's going to be a, $149 installation, something where I think that's how you're going to get in the cost curve. And I know Brett had a comment, so I'll stop.
Sure. I think to your point, Gary, except for Medicare right now with remote patient monitoring, there's no direct reimbursement. But as I mentioned before, the pandemic, we were looking at preventing readmissions with CHF and COPD, huge ROI there. And then I think as we shift into more of a value-based care world, Kentucky, we're not there yet, but as you prepare for what's coming, you have to be able to keep your folks healthy and out of the hospital. It's one of the benefits to the pandemic and things like remote patient monitoring and televisits and things. It's exposed so many more providers, administrators to the possibilities. Yes, we had to throw this up quickly, and there were some holes in it and things like, but the possibility now. The challenge for me really is getting back around to some of these key leaders and say, how else do you want to use this? Like COVID, let's say COVID's gone. Your post-op visits. Do you want someone driving from Eastern Kentucky to Lexington just to show them your appendectomy scar? Like, really? Could we do that by video? Could we do that in different ways? And there's data out there to support some of those things as well. So I think the ROI from a just strictly reimbursement piece, that you're spot on. You have to be careful with that. However, I think if you can take a broader perspective, it's already there, and I think should only grow. And honestly, one other thing, once we can show that, like internally in our offices and our organizations, then you go to the payers and say, listen, we both win. Start paying for this.
Exactly, right. Maria, would you like to talk a little bit about Medicaid, the technology, the barriers, and also maybe a little bit about the parity relative that was put in place for Medicaid and as it relates to new services and some of the existing services covered by Medicaid?
Well, I was just going to comment quickly on what was just said. I do think that a lot of this technology was out there and no one was using it. And COVID was kind of like the kid that pushed you off the high dive. Most people need a push to jump off that high dive the first time. And, some kids will run and jump off, but most need a push. And so COVID was that push. It just pushed the providers off. And and you had to dive into the deep end. But this is really good because now the providers are getting buy-in on how many barriers the telehealth, gets rid of, and how many different ways you can use the technology. So I think that's really great. With Medicaid, we actually had a regulation for telehealth go into effect in July of 19 for parity for telehealth versus in-person visits. And I don't think anybody really took advantage. Well, I know nobody took advantage of it, but I don't think people realized that. So when March 2020 came and we changed our regs to allow more providers and different things like this, after that, providers were asking, well, when are you gonna, can we have parity after the public health emergency is over? And our response was, well, you actually had parity before the public health emergency happened. And so I think Kentucky was really ahead of the game as far as that kind of stuff goes, much better than a lot of other states. We were ready. And so we're looking at other things now. You're looking at what did we not have in that regulation that people are going to want, for example, remote patient monitoring. And I think this is really how we can work as a team with payers and with providers and hospital systems to really drill down what is beneficial, what do we really need to do, and what do we have to make happen. And I think that's the bottom line, that we have to use this as a springboard and move forward, because it really is a great opportunity.
Yes, yeah. So let's shift a little bit to talking about health information exchange, Kentucky's Health Information Exchange, Health IT, and how your organization was helped through this pandemic, either through use of the ePartner portal, alerts, notifications, the ADTs, the ability for those to be sent, electronic lab reporting, electronic case reporting, potentially immunization records of patients to see if they've gotten their flu shot, given the scenario that we're in. And also you could add to that, where would you see some opportunities in this pandemic for the HIE or for Health IT to play a greater role in helping to solve and put all the parts, so to speak, together? Because we have come, telehealth got as we've said, and when I talked to our director of telehealth, Donna Vino, here at the state, we did 6 months of work in 6 days. And so people just moved. Now thinking about the overall broader technology and health information exchanges, lab reporting, case reporting, we all have seen how that, and I think Dr. Stack addressed it in how the commercial labs who have come into the state to do a lot of this testing are now going through the health information exchange so that patient's record is now available to you as providers to know they were tested. This was the result. And oh, by the way, of course, it goes on to the Syndromic Surveillance Registry and to CDC. But from the point of care, there's more information than we've ever had in the past. So I'd like to maybe open it up with Gary a little bit about from the academic and perspective of HIE's role during something like a pandemic. And then we'll lead from that view to the practical view that the clinicians have experienced.
Sure. One of the major challenges in interoperability, and we all know there's, it's an evolving it's an evolving solution and will always be an evolving solution. But the whole area of registries and capturing data is one of a very high priority for all providers based upon what they're required to report to various states. And on a national level, one of the problems you have is that there's a real sort of lack of standardization in registries, right? So if you're in a state, you have to report using basically the registries, the standards, the products at that state. So you've got basically 50 states and 8 territories, and the vendors are supposed to be able to allow electronic health record to capture and report to those registries. The eHealth Exchange is supposed to provide the interfaces, and it's a very complicated thing to get any sort of scale economies, right? For the vendors, I mean, it's one thing to report electronic clinical quality measures under MIPS or MACRA to CMS because that's a national standard and you can scale that across all your customers. But if you're trying to scale sort of registry reporting it gets really complicated because of the heterogeneity of the standards and the registries, and it goes beyond it goes beyond it's diabetes, cancer, all the registries that we really need to be tracking. So that that is an issue. So you have you have the 50 laboratory problem or 58 laboratory problems, right? Each with their own solution. So that's an issue. Also, just some of the standards as they've evolved. I mean, we know that electronic lab reporting, essentially using the LOINC standard, has had a lot of challenges and a lot of issues, both on the EHR side and on the registry side. So I think that there has to continue to be some focus on improving standards. And I think that the good news is everybody now understands the importance of working on these in a quicker time frame. The urgency had never really been there before. The other point is, when the ONC is probably right now, they're talking about as much about immunization tracking as they are about, COVID tracking. So at least we're finally looking forward to the next 6 or 12 months, right, in terms of bidirectional immunization exchange, which has always been a challenge. So, we have the infrastructure in place, and everybody's doing their best to work around it. KHI, once again, and I'm certain you heard about it earlier, in terms of the commercial labs, is really one of the leading states in terms of engaging the commercial labs for capturing data. That is not a common occurrence in most other states. So, there's always sort of an issue of where you're positioned. And as I mentioned earlier, many states don't even have health information exchanges who are attempting to solve some of these problems. So I guess just in summary, I mean, we've always known we've had issues with some of the standards and the implementation of the standards, lab reporting, public health reporting, and the fact that it's so expensive. We really can't expect the electronic health record vendors to be able to solve the problems all at once because they have so many different customers, so many different locations. But at the same time, I think now we're finally realizing it. I know there's a working group driven by the CDC on immunization reporting, trying to really establish a much more efficient solution to that. So, we knew interoperability was a problem, but I think now we're really able to focus on particular issues. And also the whole issue of population health mentioned earlier, disproportionately affected populations, be they, Native American, be they African American or corrections. Corrections was ravaged in many parts of the country by COVID. So, from an academic perspective, right now we're just describing and still documenting, but hopefully driving some of the solutions. So.
Dr. Wright, would you like to talk a little bit about HIE, interoperability, and other technologies that have assisted and helped managing during this pandemic?
I think Gary laid it out so well from an outline and just a broad perspective of what KHI can do and what a health HIE can do. I proudly serve on the clinical advisory committee for KHI, and just, so I'm biased. I'm a fan. I give time to make sure KHI does great work. And I think that what we really understand, that we have a responsibility. There's, again, I keep looking down here, how many people, we're above 140 people on this call. I think if you're going to have data interoperability, you have to have a commitment to have that. I think it definitely is. It's a tech game, but tech doesn't always solve it. It has to be a ground game. And that's where people need to ask for it, need to understand and have clarity. To be specific and answer one question, Robert, on how I think KHI could help, I think if we had a post-COVID syndrome surveillance unit, I think it would help a lot for people in this state who have COVID and are experiencing different COVID symptoms, because I've heard of other states, very prestigious academic medical centers having this, but I think that we could have this here. I think KHI could help spearhead that. That's just my comment. Thank you.
Great idea. Great idea. And we have actually had been in discussions with Commissioner Lee at Medicaid Services regarding being able to follow post-COVID patients, and what health effects, what diagnosis, et cetera, have occurred in the future post the pandemic, and they're dealing with the disease. So that's on our radar, definitely. Now, how that practically, from just an analytic study, but to a practical surveillance unit is a great point. Dr. Oliver.
Just add a couple of things. One, even as we've advanced things so far, to piggyback on the immunization discussion, so we've got all these vaccines in the pipeline, different distributions, different storage, different follow-up, 1 dose, 2 dose, 21 days, 20 days. I mean, is that not what technology is perfect for? And yet the government's going to give us a little paper card to fill out to carry around with us. So that's the reality of where we still are. As far as the HIE goes, I mean, by its nature, it's gathering data from multiple sources and filling in those gaps of care. I've got good data when the patient is within my system and it's presented to me in usable ways. It's when they're not, when they're in the black hole of a post-acute setting. A black hole meaning data. I don't know what happened at the nursing home. I never know until they show back up in the emergency room. How can we fix that? Can the HIE, whether it's an ADT notification or hopefully it's even more robust than that, fill in those gaps? One specific example that we're working on right now with KHI is using their ePartner viewer. The recommendations for treatment and testing, quarantining, all those recommendations, they're changing all the time. And it really does matter where in the course of that positive test your patient finds themselves, and whether it's treatment or can they get out of quarantine, those kinds of things. It's important where you administer steroids, where you don't. And so we're trying to use the ePartner viewer as a way that when they're not in our system, we don't have records on them, of querying that to say, not just that they're positive, that we kind of know that they showed up in the ER and they've got COVID symptoms. We can repeat the test, but that's not helpful to know where they are in their disease state. And so be able to look in there, query that, whether it's a manual process or we're able to automatically do that. And then one last thing, I think if we can keep an eye on all the data, like this is great. Data exchange is so critical to good patient care, but to remember that the frontline provider cannot handle all this data. In our organization, I'm telling myself, we celebrated having Fitbit data brought in if the provider ordered. Listen, I did it on I don't want my Fitbit data. That's not helpful to me. It's noise. Now, if you could give me a pop-up that said, Brett typically has, moves this much in a day, in the last 2 weeks, it's remarkably different. You might want to check in on them. That's useful. And so as we're bringing all this data together and presenting it and celebrating it, let's make sure we're not overburdening the person who has to make the decision on care and giving them usable things. So that's mine. Thanks.
Great point. Before I move to Medicaid, I'd like to just make a few comments. You guys are hitting on great ideas, and I did not hand you Gary's syllabus. But there are actually projects coming up, you will hear this afternoon, I hope, about one was very interesting in getting testing and lab from nursing homes and the route the state wanted to go versus some of the federal instruction, which, as you said, was kind of like this versus automated, or at least at the minimum data entry that actually got it into a system very quickly. And so we do run into sometimes those conflicts of the best way to get the information and to integrate the information. I think one of the other things that as we move forward, we'll be looking at is the usability of the important information in various roles and scenarios that is provided in the provider portal, and whether it's integrated with your EMR or EHR, and that's how you access the data, or whether it's the pure portal itself and on the web. We're at the point where it's time to fine tune some of the usability parts of it and the priority of that data that helps someone make a decision quickly but accurately. And so we'll be hoping to launch a study here in the new year, working with providers and looking at how they actually use the clinical data coming from KHI within their EHR or potentially natively within the portal, and what is important. I just want to thank the KHI team, the technology team here at CHFS, and Deloitte, and really the vendors that work with Deloitte, Verado, and Philips. When we had this conference about 15 months ago to where we were literally a month before the pandemic, amazing movement and completion in our platform. Amazing features that allowed us to, within 2 weeks, do things like alerting about COVID. If a patient checks into your hospital, they know that, oh, this one already has been tested. The alerting around hospitals, ED visits, the platform that has been built and has sustained and has stayed stable during this time period, allowing us to quickly add lab reporting, case reporting. I am so thankful for the work that has been done and the foundation that we had in place live, and then just simply could enhance throughout the COVID pandemic. So again, I can't be more grateful to the team, the whole team, in getting us to the point where we were with the KHI platform and the replacement of the older technology, so that when COVID did hit, we weren't scrambling to build, we were scrambling to enhance. And so that has been a blessing to us as a state. So Medicaid, would you like to talk a little bit about the HIE and the things you saw that assisted during the pandemic and opportunities you see for the future?
Well, I think it's actually been phenomenal. Just like the possibilities with telehealth, I think the pandemic has really forced providers and others to see the benefit, to recognize that the HIE is there, that they see the benefit of it. They can get information, like Dr. Oliver was saying, on patients that haven't been in their system. It's just better patient care to be able to have all that information at your fingertips to take care of people. And again, I think it's been highlighted during this past year of how important that is. And I think it's making, reducing buy-in, so people will really support it and be, and expect it to be useful in the future. So I think that's really great. I think thinking about immunizations and tracking those, and with going into 2021, it's going to be so important. The registry will be, and hopefully that will make things expand. to really make the immunizations mandated, to mandate everyone who gives an immunization, no matter what age, in Kentucky, has to report it to the registry to make it a more robust registry. I think that's very, very important. And I think this is going to help. I think the pandemic is going to help really show people how important those